Thank you everyone for coming. We're very excited to offer this, our very first questions answered webinar run by the Canadian Autoinflammatory Network, or the Réseau Autoinflammatoire Canadien. We are hosting these as a function of an outpouring of our Autoinflammatory Hour events, which run monthly, which is a place where autoinflammatory patients can come together and talk through in a community of practice through their own experiences and their struggles. And we are, as we go through those every month, we have acquired a bunch of questions, and those questions have borne out into this series. And so the first of this is on genetic counseling. So today we have with us Valérie Poulin and Géraldine Gosse, who are genetic counselors, come to speak to us about how this functions in largely in the Canadian system. And we are excited to have them. So at this point, just a couple of clarifications. Currently, everyone's cameras and chat functions are off. We do have a question and answer function in the Zoom call that you can use to ask questions as you are going through. Feel free to ask the questions throughout the presentation, but we won't be answering those questions until the end of the presentation. Furthermore, just want to clarify that at this time we are recording the webinar for posterity and for those who can't make it with us today. Depending on the questions, though, the questions that we have asked, we may cut those from the webinar. But just to clarify and ensure that any questions asked, please make sure that they are not of a personal or diagnostic nature, but they are questions pertinent to genetic counseling in general. And so with that, I'm going to hand it off to our presenters. And yeah, let's get started.
Okay, so I'm going to start. Do you see the presentation mode or?
We see the presenter mode, so we just need to do a flip.
Okay, great. So you see the presentation and my mouse? Perfect.
Excellent.
So hi, everyone. Welcome. I'm Valérie Poulin, genetic counselor, and I'm here today with my colleague, Géraldine Gosse. And today we're going to talk about genetic counseling and autoinflammatory diseases. So for the content of this presentation, it will be divided into three main parts. So the first part will be Genetics 101. So I will review with you basic notions of genetics. And in the second part, we'll talk about genetic counseling, genetic testing, and beyond. And for the third part, Géraldine will talk to you about more specific genetic aspects of autoinflammatory disorders. And before starting, I would just like to disclose that we do not have any conflict of interest to declare. So Genetics 101. So you may be familiar with DNA, with this structure here. DNA is the genetic information that we inherit from our parents. And it's present in all of the cells of our bodies. And it fits in the cells, in the small cells, by condensing into structures called chromosomes. Chromosomes looks like this, so they're like X-shaped. Oh, there's someone coming right now. Okay. So chromosomes, it says here above that chromosomes can be viewed like chapters in a book. And one set is from the mother and one set is from the father. And genes are like sentences in those chapters. So they contain a short section of information. And finally, variants or mutations are like misspelled words or spelling mistakes in those sentences. And they could be only a small letter that changes in the DNA, or whole words or whole sentences that can be missing also. So that's basically it for Genetics 101. So to put all of that into words, just to review a little bit, so DNA is like your recipe book that we have in 2 copies, one from the mother, one from the father. And chromosomes are like chapters in those recipe books. And genes are like recipes in those books. So they have a specific information to produce a specific protein. And proteins, well, they are a molecule that have specific function in our bodies. So it can be like insulin or hemoglobin or any part of our bodies, really. And finally, variants or mutations are like spelling mistakes, and they can sometimes lead to genetic diseases. So now I can go a little bit further into genetic basis and talk to you about genetic transmission. So you may know that humans have 23 pairs of chromosomes, and there's 1 pair of sexual chromosomes in those. So for those who don't know, females or a woman have 2 X chromosomes, and people who are born male or men have 1 X and 1 Y chromosomes. And the other pairs of chromosomes, the other 22 pairs, are called autosomes, just so you know. So, and in all of those chromosomes, we have more than 25,000 genes in total that are dispersed throughout the chromosomes, and each are present in 2 copies. So that's really important to understand. And so some of those genes, they follow what we call an autosomal recessive transmission, other an autosomal dominant transmission. And for those on the X chromosome, they follow an X-linked transmission. So I will talk more about these in the next slides. And just a side note here that I told you that we inherit DNA from our parents, yes, but sometimes mutations can appear in a child. So sometimes variants are not inherited from parents, and we call them de novo variants, just so you know. Okay, so autosomal dominant transmission looks like this. So basically, it means that when we have 1 mutation on 1 copy of the gene, it's sufficient to cause the disease. So it dominates over the other normal copy, and we express symptoms. We have symptoms, we are affected by the disease. And it also means that we have a 50% probability of having an affected child. Because each time we have a child, we give half of our DNA, so 1 copy of gene or the other copy at random. So there's a 50% risk of having affected child. And in a pedigree, in a family tree, it looks like this. So just to understand, the squares are men and the circles are women. And blue filled shapes are affected people. So as you can see, there's people affected in each generation, and about 50% of the people are affected by the disease. So it looks like this for autosomal dominant transmission. And now for recessive transmission, it's kind of the opposite. So it means that when a person is affected by this kind of disease, they have a mutation in both of their gene copies, okay? And when we have only 1 mutation on 1 copy and not on the other, like so, we are not affected by the disease. We are what we call carrier of the disease, but we don't have any symptoms. And it's only when there's a risk to have a child affected, it's only when both of the couple members, both partners, have a mutation in the same gene. And when both are carriers, like so, they have a 25% risk of having an affected child and a 50% risk of having a carrier child with no symptoms and 25% of having unaffected child. And for a person that is affected by this kind of disease and have children with a person that's not a carrier, there's no risk of having an affected child, but all of the children will be carriers of the disease. So that's good to know. And in a family tree, it can look like this. So it can look like only 1 person is affected in a family, but it's still genetics, and parents are carriers and other people in the family can be carriers. So it's good to test the family members to see who are at risk of transmitting the disease. And typically only 1 generation is affected. So it can be siblings, but not every generation. Okay, and finally, for the X-linked transmission, It's kind of like a recessive transmission, but with a twist. So here you can see women have two X's. So when they have a mutation on one X chromosome, the other normal copy compensates for the other. So they don't have any symptoms, but they are carriers of the disease. But for males, they only have a short Y chromosome, so it doesn't compensate for the X that has a mutation. So they have symptoms and they are affected by this disease. So typically, it's only men that are affected by this kind of disease, X-linked transmission. And so the risk for having an affected child for a mother that is carrier, it depends on the sex of the baby. So if she has a son, well, there's a 50-50 chance of having an affected son. And if she has a daughter, there's a 50-50 chance of having carrier daughter or unaffected daughter. And for it's interesting here. So for the affected males, if they have children, well, there's no risk of having an affected child here. And so if they have a son, they transmit their Y chromosome. So any of the son won't be affected and won't be carried. And for if the man has a daughter, well, they will all be carriers for sure, 100%. So that's it for the transmission. And now we can enter part 2. So part 2 will be divided into 4 subparts. So A, B, C, and D. And I will talk to you about A and B. So pre-test genetic counseling, what are the possible tests, possible results. And Géraldine will go a little bit further into the implications of those results in family screening, family reproductive, also genetic counseling. So before entering that, what is genetic counseling? Well, it's a process, okay? And it involves helping patients and their families to understand and adapt to the medical and psychological implications of the genetic diseases. It also provides support to patients so they can make informed choices about genetic testing. Also, genetic counseling is based on several fundamental principles, including information is power. So it means our goal is to empower patients to have more the information they need to make informed choices. Also, empathy is quite important. Non-directivity, which means we don't tell patients what to do, it's their choice. Also, a non-judgmental attitude, sensitivity to psychosocial issues, so which can affect the decision-making process. So it's important to take into account, as well as ethical and legal matters if there's some. And who are genetic counselors or GCs? Well, they are health professionals, not doctors, but health professionals with a master's degree and with a specialized training and experience in the medical genetics and counseling. We are about more than 600 in Canada right now. There's more in the US. It's still a new field in Canada. And most are certified by the Canadian Board of Genetic Counseling, the CBJC. So for the pre-test genetic counseling, so it's the first genetic counseling session that you have and the main one, which includes 2 main parts. So the first part, we ask questions for the patient and the family. We ask the medical history. We ask also your family history, and we draw the pedigree that you see right here. We draw the family tree to interpret better the disease risk, if the disease is genetic, and if so, which people are at risk in the family. And after the second part is a discussion period where we give you a lot of information. We first talk about genetic aspects of the disease. So we talk about what are the genes that are implicated, what is the genetic transmission that I talked to you about earlier, and also what are the clinical aspects of the disease. So we tell you a little bit what to expect in terms of symptoms, in terms of prognosis, and also medical management and treatment. So we answer basically all of your questions regarding this disease. And also, of course, we talk about the genetic test that we offer. So we tell you why we offer it, what it is, how it works, what are the possible results to expect, what are the implications also for you and for your family. So at the end of all of that, we can obtain your informed consent. So it means knowing all of this information, do you choose to go ahead with the test for you or for your child? So it's genetic counseling in a nutshell. And now for the possible genetic tests that we can offer in a session for autoinflammatory diseases. Well, the vast majority of the time, we offer gene panels. Gene panels are sequencing or reading a select group of genes. Okay, so it's like scanning or reading all of those specific sentences to look for spelling mistakes in those genes. And I just a side note here, I say offered in the clinic, most of the time they're covered by Medicare. So when there's a medical indication and when there's a strong suspicion of the genetic disease, those tests are covered and they're free in Canada. So other type of tests that we can offer are exome sequencing, which means testing all of the genes. So not a select group, but all of them. It's more rare to offer those. Sometimes they can be offered when there's severe cases and pediatric cases. And also they can be offered when gene panels are negative. We didn't find anything, so we go larger and we can test all the genes sometimes. Okay, so it's a case-by-case basis. And sometimes when it's not covered in a clinic, it could be offered in a research basis sometimes also. Also, just so you know, there are other types of genetic testing, but I won't talk to you about them. But you feel free to ask questions at the end about them if you want to know. And also, just good to know here, genetic testing is mostly done on blood, but they can also be done on other types of samples like saliva or cheek swabs. And just an example for me and Géraldine, we often see patients that live quite far from where we work in Montreal. They're in Quebec, but far from Montreal. So it's convenient for us because we can see them virtually, like right now, like a video chat, and we can ship them the saliva kit to do at home, the saliva swab, and they can ship the sample back to the lab. So it's more convenient that way. So good to know if you live far from a genetic counseling clinic, it can be done sometimes. Okay, and now after the test is done, there are many possible results that we can have. So I'm going to go through them with you to better understand the possibilities. So first, the possible result can be positive. So positive means we found something. We found a variant that is a cause for the disease. And it happens about 40% of the time. And this number comes from an article on immune defects. So it includes autoinflammatory disorders and also immune deficiencies. So about 40% of the time, it's not bad, but it's less than 0.5% of the time. So the next possible result is negative, which means we didn't find anything in the genes that we tested. Okay, but it doesn't mean that the disease is not genetic. I want you to understand that the test has limits. When we test a select group of genes, maybe we can offer another test when there's a strong suspicion that it's really genetic. Maybe there's something that we missed. So we go larger, we offer an exome. So yeah, just so you know, it also decreases the risk for the family members. So when it's negative, we're quite confident that the risk is lower, but it's not zero, the risk for the family members, even if the test is negative. Okay. So the next possible result is a VUS. So it's the complex one, and it's called the variant of uncertain clinical significance. And I will talk more about it in the next slide. And lastly, the last possible result is an additional finding. So it means that we found something, but it's not linked with the symptoms and the disease. It's linked with a risk of another disease that we did not expect to find. Okay, so it can be, for example, a risk for cancer or stuff like that. And good to know here about the possible results. There's a Genetic Non-Discrimination Act. That is a law now in Canada. So it makes it illegal for insurance companies and employers and other people to ask for a genetic test result. And also they can't use it. So even if they have access to it one way or the other, they can't use it. They can't use it to raise the prices or make you non-insurable. So that's really good to know. And if you want more information, I have put the link at the end of the presentation. Okay, so now to understand better the possible results, there's different kind of variants that we can find by genetic testing. And we classify them into 5 different categories. So the first 2, benign and likely benign, you will not see them because they're not reported on the results report. In fact, we all have small changes in our DNA that makes us unique, but they don't cause disease, so we don't report them. And VUS are like the gray zone in between. So it means variant of uncertain significance. So it means that we don't have currently enough data to know for sure, to be certain, is it benign or is it disease causing? We're not sure. So what we can do to be more certain, we can wait for new studies and new patients with the same thing, or we can also do familial testing. So the principle here is to test family members to see, do they have the same variant? And if so, do they have the same symptoms? If so, it can guide us. It's the clue that it's possibly the disease cause. But if they have the same variant and none of the symptoms, well, maybe it's benign and the cause is elsewhere. So, and the more people we test in the family, the more we can be confident about our interpretation. So that's basically it for VUS. And now for the last categories, likely pathogenic and pathogenic, it means disease causing. So when we find a variant, it's likely pathogenic or pathogenic, it can lead to a diagnostic, which is the goal of genetic testing most of the time, is to find a diagnostic. And so we can have also a better idea of the prognosis, so what to expect. Also, a targeted therapy is often the case, that we can target or adapt the treatment better to the affected gene and affected pathway. And it also enables familial screening and reproductive genetic counseling. So Géraldine will talk to you more about those last 2 points in the next slides. So Géraldine, the floor is yours. I will stop share and let you share your screen.
Thank you, Valérie. Hello, everyone. So I'm going to share my screen right now. Here we go. Is it on? Do you see well? Can you hear me well? All good. Perfect. Thank you for being here today. I will start by presenting you about familial screening. So why would we do familial screening? The first goal is to test members of the family who have symptoms in order to confirm that they are affected by the same disease as our patients, in order for them to have the best medical care. Also, it is important to test which side of inheritance is affected. So where does the variant come from the mother's side or the father's side, in order to inform at-risk family members on this side of the family. Also, when we do familial screening and the person is positive, it will allow us to know if the person is unaffected right now, if this person can be affected in the future. Also, it will inform us if this person has a risk of passing on the disease to their children. And lastly, as Valérie just discussed, in cases of VUSs, it really could help us interpret the results, the genetic results better, and maybe reclassify the VUS as a likely benign or likely pathogenic variant if the family is big enough to test everybody, and if the presence of the variant correlates with the presence of the disease, and the absence of a variant correlates with the absence of a disease in family members. Here we are. So who should we test in the family? It really depends on the mode of inheritance. So with autosomal dominant diseases, as you know, there's a 50% chance of passing on the disease. So we can test the children of an affected person for sure. And then we would go on and test the parents in order to know if this is a de novo variant or if it's maternally or paternally inherited. And if it is indeed inherited from a parent, then we would test the siblings of this person. And we would proceed with cascade screening. So it means that we test first the first generation, so parents, and then we go on we follow with the next generations, because if a person is not a carrier and not affected, then there is no risk of them to transmit, to pass on the genetic variant to the next generation, because there's no skip of generation with any of the genetic diseases. That's a myth, actually, that is pretty common. And for the autosomal recessive diseases, we usually confirm that both parents of an affected person are carriers of the disease. Then if we confirm it, which is most of the time, then we can test the siblings, because they are also at a 25% risk of inheriting both copies that are mutated and be affected. And there is always the question, should we test the partner of an affected person? It really depends on the carrier frequency in the population for this disease. So if it's very, very, very rare and there's a very low chance of this partner to be a carrier of a genetic variant in the same gene, then we would probably leave it there and tell them that the risk for their children is very low. But sometimes with a bit more frequency in the population for carriers, we could test it. And also in the case of consanguinity, we systematically test partners. When I say consanguinity, I mean that if an affected person and their partner have common ancestors, for instance, if they are second-degree cousins, then they have a higher chance of being carried. The partner has a higher chance of being carrier of one of the two variants, the same variants as the patient. For X-linked disorders, we would start by testing the mother, because there are de novo cases as well with X-linked disorders. It's not uncommon, so it's something we should test. And then if we confirm that it's inherited from the mother, then we can test the siblings, so potentially affected brothers, and the carrier sisters as well. We want to know if they are carriers, which happens 50% of the time, as you already know from Valérie's presentation, and their children as well. So the females are the carriers, and they can pass it on to their male children. So and you can extend also the familial screening to the mothers, to women in the mother's side. Yes, so to know their risk for their offspring. Reproductive counseling. So the goal of reproductive counseling is to inform the couples of the risks for their future offspring. We help them to make the best choices based on their values, their culture, and the plans for the future. Do they want one child? Do they want several children? And their socio-economic situation is very important to take into account, because some reproductive options are expensive, and I will talk to you more about that, but it's a factor definitely to take into account. We are the non-directive genetic counseling is even more important in this type of genetic counseling, because we really want to respect couples' autonomy and freedom of choices. We don't want to influence them towards one of the options that are available. So what are the possible options that we can discuss with couples? It's also, of course, it's a case-by-case discussion. We don't discuss all of the possibilities with all the couples, but yes, it could. I'm going to expose them to you anyways, because I think it's an important information. So most couples choose to go through a normal pregnancy and then to test the baby after birth. And the age of testing would depend on the age of onset of this particular disorder involved. Then we have the option of pre-implantation genetic testing, and I will talk about it in the next slide. But basically, it's testing embryos and to see if they are affected or not. And yeah, I will talk to you about it more in detail. Prenatal diagnosis. So this is testing the fetus during the pregnancy, and I will talk to you about it as well in my next slide. There is also the option of sperm or oocyte donation if the parent is okay with their child not to have the same, not to be biologically linked to them. Sperm donation is definitely easier than oocyte donation. And we don't offer very often the oocyte donation because for cost reasons first, because this technique is more expensive than a pre-implantation genetic testing. It's about $30,000 compared to the pre-implantation genetic testing, which is around $15,000 to $20,000, which is a big difference. And usually with the pre-implantation genetic testing, the children are related biologically and genetically to their parents, so it's not usually something that people want to go through with the oocyte donation, but it's easier definitely with the sperm donation if the person affected is male. There is also the option of adoption, that some couples go through this option and they are really happy with their family. Reproductive, yeah. So for the pre-implantation genetic testing, the process is first an in vitro fertilization. So what scientists do is they inject a sperm in an oocyte. Well, they do that for several oocytes and several sperms. We have to have like a pool of embryos. And then as the embryo develops, there are a few cells that are biopsied from it and then genetically tested. And the embryos that are not affected by the genetic disease could be implanted in the mother's uterus afterwards. So that is the basis of the technique. But as I said, it's the main inconvenience in there is that it is very expensive. Sometimes it can be covered by the healthcare system. It is very new in Quebec. It started in March 2024. It has been covered for the most severe cases and the ones that are life-threatening and which don't have any treatments. So it is a case by case again, but it's much better for the couples who want to go with this technique. We're very happy about it. And then there is the technique of prenatal diagnosis. Most patients with autoinflammatory disorders do not choose this option. But it's always a possibility if it's really accessible, if the disease is severe, life-threatening, usually early onset, and if there is no treatment available again. So it is covered by the government. And so what it does basically is that the idea is to sample cells from the baby in utero during the pregnancy. It occurs about around within the third month of pregnancy, and so there can be sampling of the amniotic fluid or the placenta a bit earlier on. The risk of this technique is miscarriage. There is approximately a 0.5% risk of having a miscarriage after the technique. And also there is a decision to be made after the genetic testing has been done. So some people would, couples who choose to go through with this technique would have to choose to terminate the pregnancy if the fetus is affected. So it's really only, these two options are really offered only if there is a disease-causing variant detected. And it really depends on the disorder. So at the age of onset, the severity, the quality of life of affected people, and treatments availability. And it could be discussed in ethics committee if the professionals don't agree, or if the couple really is willing to go through these techniques, but yeah, it can always be discussed. So I'm going to talk to you about more in detail about the genetic aspects of autoinflammatory disorders. So a quick reminder of what an autoinflammatory disorder is. It's part of a group of disease called inborn error of immunity, or primary immunodeficiencies, or PIDs. The definition is any inborn defect of one or several elements of the immune system. It could be a defect in quantity. It could be like some cells missing, antibodies missing, or any other type of problem, or their function. Usually that's what we see in some proteins are non-functional. Then there are, from the classification of 2022 from the Immunology Society, there were 485 disorders classified in this category of PIDs and 500 gene defects. And since there has been more discovered, so it's a change. Every year we discover new genes, new defects, new disorders. So it's really important to keep up to date. And it's been 2 years, so they are due to make a new classification for 2024. We don't know when exactly it's going to happen, but it takes a lot of time for them to review all the literature out there. So I think it's going to be at the end of the year, probably. So here is a table showing the different classifications of PIDs, and the one that interests us today is the autoinflammatory diseases. There are 56 disorders, 56 genetic defects, and 59 disorders reported. And just so you know, these autoinflammatory symptoms can be seen in other PIDs, in other categories. So it's always important to keep in mind that it's not always, well, autoinflammatory diseases are classified as such because it's the main characteristic of the disease, of the symptoms, but it could be, there could be overlap between these symptoms and other primary immunodeficiencies. So what does autoinflammatory means? So auto means by itself, so it's triggered by the body itself. And inflammatory means, it comes from inflammation, which is a defense mechanism of our innate immune system. It's in response to any pathogen like viruses, bacteria, fungus. Usually it's triggered by that, and it's important. It's an important defense. And it can lead to fever because some pathogens are sensitive to high temperatures, so it can kill them. It's very efficient. But the problem in autoinflammatory disorders is that it's not triggered by an infection, and most of the time it's exaggerated or uncontrolled response of our immune system. So the thermostat is really unbalanced. So you know more about it than myself, of course, because you are your own specialists for your own disease. But here is a summary of the different symptoms that most patients can experience. So there's the recurrent fever, the chills, the muscle and joint pain, the skin rash or hives. There can be gastrointestinal symptoms, the diarrhea, and inflammation of the internal organs. Like, for instance, you can have elevated hepatic liver enzymes. And also there's a common complication which is called amyloidosis. That complication is the accumulation of protein linked to inflammation in some organs, especially the kidneys. It's a long-term complication that can happen. And we also have some cases with ulcers in the mouth or in the genital areas that can happen. It's pretty common as well. So these disorders are very complex genetically, which means the diagnosis can take a lot of time, or it can be very complicated. So there is variable expression, which means that even within the same family with the same genetic variant, there can be differences in severity of the disease, of different symptoms. The age of onset can be different between patients. So it's really important to keep in mind that not everyone has the same profile, even within the same family. And there's also another notion that I would like to understand is the incomplete penetrance. So the penetrance is the proportion of people who have the genetic variant and who develop symptoms of the disease. So when it's incomplete, it means there's not 100% people who will develop the symptoms if they are carriers or if they have the genetic defect. So some carriers, especially for autosomal dominant disorders, do not develop any symptoms, or they have very mild ones, which are interpreted as like no symptoms at all. So it can really mimic like a skip of generation in the family for this disease, but it's not the case. It's just that the people just never develop this disease because if it's a milder one. There is a lot of overlap and similarities between the disorders, which means we have to test many genes at the same time to make sure that we cover everything. So one gene, let's say, variants in one gene can be associated with several disorders, and one disorder can be caused by variants in multiple genes as well. The reciprocity is true as well. So that's another level of complexity. We have discovered within our clinic as well, new genetic variants that were unknown before, and they're just present in one family. So in the families we see, so it's a bit harder to classify their variants directly to pathogenic or disease-causing variants. Usually they start by being VUSs, and then we reclassify them later when we test all the family members, because there's not enough scientific literature to classify them as such right away. There is a lack of scientific knowledge sometimes in these disorders. It's it's something that health professionals have to keep in mind as well and be very informed. Don't worry, this is just a table to show you like the genetic heterogeneity of these different disorders. As you can see, there are many genes, many different disorders, and the letters AR is for autosomal recessive, AD is for autosomal dominant, and XL is for X-linked disorders. As you can see, these are classified in function of the main symptoms they present with. Usually it's an association of symptoms which are called syndromes. So this table is really useful for us professionals in order to know like, oh, this is more like a Cardi-Goutier syndrome. So these are the genes that I should look for. And it could be recessive, it could be dominant. Anyway, it's just to have, this is the big picture for the 59 disorders in autoinflammatory. And there are just 2 X-linked disorders in this classification, just so you know. The rest is autosomal recessive or dominant. I would like to present you with a case that we saw in our clinic. And by the way, we are an adult clinic in immunology, so it's great for us to see children. Usually we see them when they are transitioning from the pediatric setting to the adult setting. So this is a family with a genetic variant in the gene NLRP3. This gene codes for a protein called cryopyrin. So it's this syndrome is called cryopyrin-associated periodic syndrome, so CAPS. And so the first person in the family to present, who we saw, was this woman. She was in her late 60s, so very late onset, and probably she was probably not really. She was diagnosed with autoinflammatory syndrome, but no other precision in her medical file. So we helped discover the actual cause, the genetic cause, and be more precise in the diagnosis. By the age of 3, she had chronic hives on the skin. She had arthritis, fevers, progressive deafness later on in their adulthood, and amyloidosis since the age of 68. And unfortunately, this patient died of COVID 2 years ago. And her children, she had three children. One is in the US, so we have not been able to keep contact with him. And but there is genetic testing that is ongoing over there. So there's one male who is affected as well, and we confirmed that he has the same genetic variant as his mother. And so he was affected at the age of 2 years old. He had hives and arthritis. And he's well treated, so he might have less complications than his mother. And there was an unaffected female as well. So the transmission ends here for this woman. The sister came into our clinic as well at the age of 65, I suppose. And she had chronic hives as well, arthritis, very severe arthritis with swelling. She had also thrombocytosis, which means high level of platelets in her blood. She had a lung disease caused by the inflammation, the long-term inflammation, and amyloidosis as well at the age of 70. And she died of kidney failure at the age of 73, unfortunately. These 2 women had a mother who died at the age of 40 of an unknown cause, and at that time people wouldn't really investigate the causes of death. And she had severe arthritis early onset, so we suspect that it was inherited from the mom. The sister has 2 children. One died from leukemia at the age of 5. we don't really know if it's related to the condition. It could be. There is a theory that it might, people who might be a bit of higher risk for blood cancers, but it's not really documented really for this CAPS syndrome specifically. It's not, unfortunately, it happens leukemia for young children outside of these kind of syndromes. And the daughter was not tested yet when we saw the mother, but this particular person had a child, a daughter who had very early onset arthritis, and she's being tested right now in the pediatric setting in another clinic. So we suspect that this person, this is probably a case of incomplete penetrance, where the mother was apparently unaffected and she had a child who was affected. So it didn't really skip a generation, but again, you know, it looks like it. It's a good example also of the progress that we've made in terms of medical care, in terms of diagnosis. The next generation is gonna be much better taken care of than the former generation. With these two women who unfortunately died from complications. So yes, just so you know, so the plus on the pedigree means presence of one gene copy affected by this variant here in LRP3. Just of note, this is the position in the gene, so 149, and this is the letter. So the genetic change, it's the letter C replaced by a letter T, just so you know. And this particular variant has already been documented. It was documented in Muckle-Wells syndrome and familial cold inflammatory syndrome for several patients affected with these two syndromes. And of course, as you understood from this pedigree, it is autosomal dominant, the genetic defects linked to NLRP3. And so minus means absence of the variant. So what do we know about the CAPS disorders linked to this gene? It's not uncommon. Well, it's pretty common. I would say it like this. In genetics, the later the disease happens, the less severe it is, and the earlier the disease started, this more severe it is. Usually, that's how it works. So on the less severe end and the later onset, we have the familial inflammatory cold inflammatory syndrome. So these people have inflammatory triggered by cold usually, and they rarely have amyloidosis in the long term. Whereas a bit later on the spectrum, we have the Muckle-Wells syndrome, which is the syndrome that these two women had. And the Muckle-Wells syndrome is more like a skin inflammation. It's the main symptom, and it's not triggered by cold. It's just spontaneous most of the time. And also there is a higher risk of amyloidosis. And on the most severe end of the spectrum, there is the Sinca syndrome, which is a really neonatal syndrome. So it's really happening right after birth most of the time, within the first 2 years. That's at least. Whereas the other two happen more like in the early childhood, but it could be a bit later on as well until adolescence. And the Sinca is really more severe with the children have very early onset arthritis and hives, and they have high fevers, and sometimes there is inflammation in the neurological system that can lead to several complications like visual and hearing impairment, early onset, and it can even lead to intellectual disability sometimes in the most severe cases. So it's important to detect it early on so we can control the inflammation for all of these syndromes. So the particular examples that I wanted to show you just to illustrate a bit the complexity of what we said, and there are particular examples that go outside of this box that we just discussed. So the familial Mediterranean fever is caused by variants in the gene MEFV. It's usually autosomal recessive. So usually most people need 2 copies of the gene mutated to have symptoms. But sometimes carriers of the disease can develop symptoms, but with incomplete penetrance. So it's not all the carriers who develop the symptoms, but it can be possible. So there is a variable mode of transmission inheritance for this particular disease. There is an atypical phenomenon as well. For instance, in the syndrome called VEXAS, there are the disorder is caused by somatic mutations in the UBA1 gene, which is on the X chromosome. So somatic mutations means they are not inherited, but they are not innate as well. People are not born with that, but they develop it with time. So the mutation spontaneously appears in one type of cells. In this particular case, the white blood cells, which use the UBA gene and this gene is more important. The protein resulting in this gene is more important in these white blood cells. So it results in men. Usually the diagnosis is made in men over 45 years old, and they have recurrent fevers, pulmonary or dermatologic inflammation, vasculitis, thrombosis, so blood clots. They have joint pain, cartilage inflammation of the ears and nose. So it's a very particular disorder, but we can still make the diagnosis with genetic testing for these people. And we confirm that no other family member is affected. And there are other cases when we have a genetic testing that ends up negative, but we have really a strong autoinflammatory pattern in the family. It can be polygenic. What it means is several genes. So because what we do, the goal of our genetic testing is to look for genetic diseases caused by one gene, but there are cases where it's polygenic. So it's the different variants involved in the disease individually contribute to a very lower percentage in the development of the disease, but it's really the pattern of different variants, the association of these variants together that really increases the risk of the person to have the autoinflammatory syndrome. And usually with polygenic cases, there's strong influence of the environment as well. So here is our conclusion for this presentation. I'm sure you understood now that there are many different autoinflammatory disorders with a lot of overlap between them. They are complex genetic disorders, so it can lead to what we call the diagnostic odyssey, which is a very long process of going through medical exams, testing, etc., etc. And usually health professionals can be a bit lost in there where they make the diagnostic until you meet one specialist who knows about them, and then they can go and make the diagnostic by doing genetic testing. So this is something we commonly see with our patients who come the first time at the clinic. They're like, oh my God, you know what I went through. It took me ages, you know, to go there, to arrive to you guys, and it was a very long and painful process. So genetic testing is very useful to know precisely which autoinflammatory disorder is involved. And the results can be very difficult to interpret. So we are happy to help patients and your physicians as well. Genetic counseling can help you understand your autoinflammatory condition better, and specifically the genetic aspects of it. And it can help your family members to get the appropriate medical care. And we can give you the necessary information to make your family plans as well. If you want to have a genetic counseling session, you can always ask your physician to be referred to a medical genetics department. Usually it's done in the main hospitals in Canada, but there is also private genetic counseling out there. So if you are interested, you can always go on the Canadian Association of Genetic Counseling website, and you will have more information to seek help if you need it. Here is our bibliography, so where we took our references and our numbers. Here are a few resources that could be helpful for you to check. So the CAGC website that I just mentioned. If you are more interested in finding out about the GINA law, you can have it right there on this link. And there is also a useful database called Orphanet, which is like a database for all the disorders, all the rare diseases, and yours might be there if you want to check it out. Thank you very much for your attention, and thank you to the Canadian Autoinflammatory Network to have invited us both to talk to you about the genetic counseling in these disorders. And if you have any questions, we will be happy to answer them.
Okay, thank you very much, Valérie and Géraldine. Yep, so now floor is open to ask questions. We have the question and answer function that's in Zoom, so please answer your questions through there. Just a reminder that the questions, please limit your questions to questions surrounding genetic counseling in general, and not questions of personal medical nature. Yeah, so do we have any questions? Just give everyone a minute here to type if there are any. So I have a question to start with. My question is, in general, how long does the process take to go from first referral through to testing to the level that you've gotten either to the first set of questions? How long does whole exome sequencing take? I think that would be a good thing to know.
You want me to start? Okay.
Yeah,
Yes. So usually it's a case by case, of course, but usually just for the genetic testing, it takes 3 months to get the results. 3 to 4 months, depending on how fast the samples are sent to the laboratory. But that's just for the analysis, so 3 months in general. Even for, it might take a bit longer, so they say maybe like 4 months for whole exome, but for genetic panels it's 3 months, 4 months for whole exomes. And for your questions about the whole process with the referral and the genetic counseling pre-test results. Usually when the first referral is done in the clinic, it is addressed to the specialized immunologist. Then the immunologist refers the patients to us, and then there's this analysis, the 3 months analysis, and then we book an appointment for the results. So I would say approximately 6 months in total. I don't know if Valérie, you agree. Maybe a bit more if I'm, depends on how fast the immunologist refers us the patients as well, I think. Because in some cases, our help is not required right away, but then multiple tests are done, and then the immunologist comes into our offices and says, wait a minute, I think there's something going on here. It might not be, it's an atypical case, and we want to go through to genetic counseling. It's really an autoinflammatory disorder that is probably genetic, and we want to go through that. Yeah, because some cases referred to the immunologists are not actually autoinflammatory disorders per se. They just have some symptoms of inflammation, but it doesn't really mean they have the whole picture. So yeah, sometimes these cases are not referred to us.
Is it possible to have an autoinflammatory genetic disease for a woman who has an uncertain genetic mutation of the X-linked variant? Maybe in another way, how common are X-linked variants when it comes to autoinflammatory diseases in your experience?
You want me to answer? You can complete maybe.
Sure. Sure.
As Géraldine said earlier, they're quite rare. There are only 2 genes that we know of that cause autoinflammatory disorders. And for females, it's really rare. I haven't seen it in autoinflammatory disorders. I know it exists in other genetic diseases that are X-linked, that that females can be symptomatic, like mild symptoms, and that males are affected stronger. But in this case, I couldn't say for sure. And also the variant is uncertain, I believe you said. So yeah, maybe when it's uncertain, it's in the gray zone. We don't know. Maybe it's the cause, but maybe not. So we don't have enough data to be sure. So my response would be possibly there. It's not a strong possibility, but I won't say no for sure. So I will open the door maybe. Géraldine, do you want to complete or?
I completely agree with you. I think we're very used to uncertainty in our job. It's part of the job, right? Yes, I agree that most female carriers of an X-linked autoinflammatory disorder do not develop any symptoms, but there are rare instances where some of them do, because the other X, which is not mutated, doesn't compensate enough the genetic defect. But again, I agree in the context of VUS, it would be less likely to happen, definitely. I wouldn't say that. I wouldn't put a label of diagnosis in this particular case, indeed. So yeah, it depends also how compatible the symptoms of this woman would be compared to other, compared to the males who are affected. Sometimes it can be like less, it could be milder, but it usually is the same kind of symptoms. Yeah, I agree.
Excellent, thank you. So next, what is the process of getting a genetic counselor? And is it a counselor who decides whether genetic testing is needed, or is it someone else? And then at what point do you come in?
Good question.
Yeah.
Géraldine, do you want to go ahead or?
Sure. Well, so it's in our clinic, it's really a multidisciplinary team. We really work together with immunologists to define which genetic testing is best for the patient. Usually the immunologist brings their expertise, their clinical expertise to say, this is the type of disease I'm suspecting in my patient. And we usually choose the laboratory or the technique and the number of genes that is the most appropriate for making the best diagnosis possible with this suspicion. So yeah, I think if you want to add something, Valérie, I don't know.
Yeah, so it depends really on the clinic and on where you live. We can talk for us. So yes, we work with immunologists, so with specialist doctors who refer the cases to us when they suspect a genetic diseases. And then for the choice of genetic test, for sure we discuss it with the doctor. But legally, we can't, genetic counselors can't request a test without the doctor's approval. So it's signed by the doctor. So we discuss about it because we are the expert in genetics. So we discuss about it, what would be the best test in this scenario. So it's a decision that we take in a team, in our multidisciplinary team, sorry. So yeah, but in other places, you could be referred also to a medical genetics clinic, and there will be geneticists, so physicians that are specialized in genetics and that are working with genetic counselors. So maybe you will go directly through there. So your family doctor can refer you to a medical geneticist clinic, and then you can be tested there. So it really depends on the case.
I think our setting here in the clinic of the IRCM is pretty unusual. I don't think there is any other clinic where there are immunologists working at the same place as genetic counselors, and we are genetic counselors specialized in this area of expertise. So I don't think it exists elsewhere. Maybe there is another place where it happens. I would be happy to meet with these people.
It's more general genetic. Yeah.
Exactly. If it's not the case, then you would have to be referred in the genetics department of your hospital, and usually it's not available in every hospital. It has to be really a bigger medical center, which has a genetics department. So yeah, that's and usually the referring physician writes down the possible diagnosis and the symptoms of the patient, and then from there the geneticist or the genetic counselor of the department chooses the right genetic testing. So this is how it usually works.
Mm-hmm. And I just want to go back. You said earlier, Géraldine, that there's also private genetic counseling companies that can offer genetic counseling. So if you don't find any ones in the public sector, there's also a possibility of private clinics in genetics, but it's more costly.
Wonderful, thank you. So the next question comes like this. When testing comes and nothing is found, what are the next tests? So even if we've gone through whole exome sequencing, or we've run into like for instance, or our family variant of unknown significance, What are the next steps? Are tests rerun on a regular basis as new discoveries are made, or do patients need to request tests to be rerun, or does the clinic do this? Does we get flagged for new data and things like that? What are the general processes for people who don't necessarily get an answer on the first run?
Usually what I've seen in most clinics is that we don't have a perfect system in order to rerun the samples and redo the sequencing in light of the new discoveries. So most clinics tell the patients, call me back in like 2 or 3 years to see if there's anything else. In our clinic, it's a bit different because usually the patient is followed up by the immunologist throughout the years in our clinic, and we are physically here in this clinic. So if the immunologist like sees the patient in a follow-up 2 years later and says, wait a minute, I think I saw this article like about a new gene that was just discovered and the patient had similar symptoms, let's do it again, you know, let's do the genetic testing again, or let's rerun it. Then they send us a referral and we do the process again. But usually I would advise patients to contact the person who did the testing, who asked for the testing, to redo it again. I would suggest to wait like 2 years for the knowledge to increase, and then yeah, I think that would be the best strategy, because we don't have a perfect way of resequencing or re-verifying in the health system. It unfortunately is a reality, I think.
Mm-hmm.
Can you, this is the next step, or next question. Could you give us some, just a re-summary of what generally needs to happen during the between the specific genetic testing and whole exome sequencing? What are usually the flags to get to that next step if someone receives conflicting interpretations or symptoms from the original, like, base standard panel?
It's a good question. Yeah.
It depends. So
I'm trying to think about different reasons why someone would go to the next step and why someone would not.
it's really when there's a suspicion that it's genetics. So that many people are affected in the same family, have the same symptoms, and it seems to be inherited. So really, there's a strong suspicion that there's something genetic there. So if we do a panel and we didn't find anything, so that's a reason to go larger, so we can do a larger panel. So 600 genes at the place of 60, or we can do exome, whole exome. Also, if whole exomes are negative, we can do whole genomes sometimes. It's really rare. It's on a case by case basis. It's rarely covered here in Quebec, but maybe elsewhere. I think Ontario is more covers more exomes and genomes. So yeah, genomes means all the DNA. So it's not, exome means all of the genes. So all of the genes that codes for proteins, so have a function that we know in our bodies. But it's only 5% of all of our DNA. So genomes test all the 95% also, which we don't know what it does, but it's there. So we scan it for mistakes, for variants. So we can do it in rare cases when there's a really strong suspicion that it's genetic. And that's really like the symptoms of the patient really fits with a specific disease that we know that is genetic. So sometimes, yeah, we go further there. We do also other types of tests, like if we didn't find some small variants, we can scan for the whole chromosomes. So with CMA, I think in English, chromosomal microchip array that we call. So it's another kind of genetic test that we can do, or karyotypes. So take a picture of all the chromosomes to look if there are whole sections that are missing or that are in double. So yeah, there's other tests to do, but it really depends on the case. And to respond to your question, it's, yeah, if the case is severe, if the case really lights something like, oh yeah, it looks like it's this syndrome. So yeah, we can test further.
I agree. I think there are different situations that I have in the back of my mind, like indeed a positive family history. So several family members affected with the similar symptoms or similar types of symptoms. And it really follows a pattern of autosomal dominant or recessive or any other type are explained. Also, yeah, if the person, we can also do whole exome if the person has other symptoms that we don't understand, that do not follow the usual autoinflammatory syndrome type, like for instance, developmental delay. That could be something that is chromosomal, as you said, Valérie. So I think we suspect more a chromosomal defect, or we involving multiple genes when there are other types of organs affected, or when we suspect other types of diseases at the same time. Well, I think developmental delays is the typical example, or intellectual disability, or yeah, I think very severe psychiatric conditions in combination with like birth defects sometimes as well. Any type of thing that can tell us, like, okay, there might be other genes involved, and then we have to test larger. So we would go through all exome, or in this particular case, more like microarray to see the chromosomes, if there's any piece of chromosome missing or doubled in the DNA.
Excellent.
But
okay.
Yeah.
So we're getting close to time, so I've got 2 questions left. The first question is, can you accept raw data to analyze? Would be the first question.
For our patients, yes, we have a doctor in the clinic that knows how to analyze this data. So for our patients, we can sometimes ask for raw data and scan it ourselves to look for variants that were not reported. So yes, it's possible in some cases, but not like from other patients that are not ours. Yeah.
Yes, that's usually our go-to in case the whole exome is not accepted by the health insurance. We usually analyze the whole exome raw data from the patient sequencing, and so most laboratories that we use for genetic testing offer it for free or for reasonable cost. So, but it takes time, though. It takes like about, they say they can send it within 6 months, so it could be.
And yeah, it's kind of a go around if we don't have access to exome, we can do that sometimes.
Okay, and so for our final question, I have Dr. Jason on here, who has a quick question for you. So I'm just going to unmute him so that he can ask his question.
Hi, thanks for the really nice talk. I think maybe my question you may have covered a little bit in your previous statement. my question was regarding your second last slide, maybe when you said that some are polygenic. And so is that just like a general statement, or are you saying that sometimes when you see a VUS, that could be one of the genetic contributors to the phenotype? So was that just a general statement, or are you referring to those VUSs?
It is indeed a general statement, but it's not excluded that indeed the VUS could contribute to the disease. Absolutely, yeah. But usually when we say when we say polygenic, it can be either rare variants or more common variants that are called polymorphisms. It's more likely that most of the variants contributing to the disease in a polygenic setting are polymorphisms, but there can be also rare variants with very mild contribution to the disease. However, I would add that we are not there yet in terms of knowledge. We are not, our genetic analysis are not meant to detect these variants in a polygenic setting. We're really looking for monogenic conditions with our genetic testing. But it's a very good thought. I think that could be definitely possible for VUSs. Yeah. But then again, what would you do with that? Would you test family members for this particular VUS that you suspect is one of the many genetic factors that contributes to the disease? I would suggest not, that you would not test the family members for that, or it wouldn't change much, I guess, also your medical approach. I don't know, the care for the patient. I don't know. I mean, it's just food for thought, but yeah.
Yeah, thank you very much. Appreciate it. Just a quick note on your other comment about access to genetic counselors. As you may know, I run an autoinflammatory clinic, and we're actually in the process of incorporating a genetic counselor into this rheumatology clinic. She's actually on the call right now. So we're definitely trying to improve access to counseling in that regard.
Oh, that's great. I didn't know it was happening. Great. That's good to know. We will be happy to keep in touch if you have any questions or anything we can help with. And it's always good to keep in touch and see what other clinics do as well.
Thank you.
Okay, and with that, we're at time now, so I just want to thank our presenters, Valérie, Poulin, and Géraldine Gosse, for their time today and their presentation. It was very good, and we're very happy to have it. I think the question and answer period was also very informative. So thank you everyone for coming. I will be putting this down as a recording, and then we will be sending it out to attendees and people who wanted to come but couldn't make it. So this will be available on our website in the near future. Thank you for all attending. If you have any questions or want to learn more about the Canadian Autoinflammatory Network, then you can reach us at autoinflammatory.ca or info@autoinflammatory.ca. It's our email. So thank you very much, everyone. Have a wonderful day, and we will hopefully see you soon.